Double Descemet membrane is a rare complication that may be observed after full thickness or lamellar keratoplasty. In lamellar keratoplasty, the etiology may be related to either intraoperative perforation leading to a double anterior chamber or a type 3 bubble formation during DALT resulting in separation of pre-descemetic layer and Descemet's membrane. Retention of the host Descemet membrane may be seen in cases of chronic edema undergoing penetrating keratoplasty, such as long-standing Fuchs endothelial corneal dystrophy or congenital hereditary endothelial dystrophy. Management may be challenging, and options include injection of intracameral air or gas or descemetorexis of retained Descemet's membrane. We describe two cases with double membranes in the immediate post-operative period and the role of OCT in their management. The first case was a 28-year-old male who was planned for big bubble dye for macular dystrophy in the right eye. Intraoperatively, successful formation of big bubble was confirmed on iOCT. Lamellar dissection was done to debulk the cornea, and a nick was made in the stroma to allow escape of the big bubble, followed by removal of the stromal layers to expose the host Descemet's membrane. The donor button was sutured on the host Descemet's membrane with 10-0 interrupted monofilament sutures. Surgery was completed uneventfully and there was no intraoperative perforation. On postoperative day 1, a double Descemet membrane was observed clinically. Two Descemet membranes were visible on anterior segment optical coherence tomography, originating from beyond the graft-host junction as a single membrane and thereafter splitting into two membranes. A type 3 bubble had formed during big bubble creation, separating the pre-descemetic layer from the stroma and Descemet membrane from the pre-descemetic layer. It was missed intraoperatively, which had led to the formation of a double anterior chamber. iOCT guided management of the case involved removing the sutures at the 12 o'clock position. A careful nick was then created in the pre-descemetic layer using an MVR blade inserted via the interface in order to remove the interface air bubble between the pre-descemetic layer and the Descemet membrane without rupturing the Descemet's membrane. Medicine sponges were applied at the edge of the interface to soak the interface fluid, and gentle corneal massage with milking of the interface fluid helped achieve complete graft apposition. iOCT helped confirm complete graft apposition at end of the surgery after replacing the sutures that were initially removed. On postoperative day 1, optimal anatomical apposition was achieved with a clear graft and uncorrected distance visual acuity of 20/32. The second case was a 24-year-old male who underwent full thickness keratoplasty for long-standing CHED with secondary spheroidal degeneration. Partial thickness trepanation was done and the MVR blade was used to create AC entry. The host button was cut circumferentially with Vanna scissors. Followed by placement of the donor tissue and securing the graft with interrupted 10-0 monofilament sutures. On postoperative day 1, the uncorrected visual acuity was 3/60 and a double anterior chamber was observed on slit lamp examination to the retrocorneal membrane. ASOCT helped to confirm the diagnosis of retained host decimate membrane as the second membrane originated peripherally from beyond the graft host junction. So where did we go wrong? A partial thickness definition at the beginning with hesitant AC entry and injection of OVD via the graft host junction could have led to host decimate membrane detachment. The retained decimate membrane was not detected intraoperatively. A posterior limbal entry was made to avoid entry into the interface, and trypan blue dye was injected to stain the retained host decimate membrane. OVD was injected through the graft host junction to form the interface space and push down the retained host decimate membrane. Descemetodexis was performed using a ILM peeling forceps from beyond the graft host junction in a circumferential manner to remove the retained host decimate membrane without damaging the graft decimate membrane. On post-operative day 1, the uncorrected visual acuity was 624 and a well-opposed graft was seen clinically and on anterior segment optical coherence tomography. To conclude, double membranes after keratoplasty may be challenging to diagnose and manage. ASOCT is the key to diagnosis, as retained host decimate membrane will typically originate beyond the graft host junction, and a split in decimates and pre-decimatic layer may also be observed in a case of type 3 big bubble formation and a separation of pre-decimatic layer from decimate membrane. Intraoperative OCT is a useful adjunct in management as it helps guide the site of entry into AC, helps avoid inadvertent interface entry, helps observe real-time dynamics during surgical maneuvers, and ensure complete graft apposition at the end of surgery. Optimal visual and anatomical outcomes may be achieved with timely diagnosis and management.